Imagine for a second, just imagine that, like deep down in your bones, that something is profoundly wrong with your body. You're experiencing this physical agony that literally drops you to the floor.
Right. It's a completely overwhelming feeling.
Exactly. But every single time you try to sound the alarm, you just hit this wall of polite dismissal.
Yeah.
Your peers tell you to just tough it out. Your family, they think maybe you just have a low pain tolerance.
Yeah, which is incredibly isolating.
It is. And then worst of all, the medical professionals, you turn to the people supposed to help. They look at your charts, pat you on the shoulder, and basically say, everything is completely normal.
It's a terrifying scenario for anyone to navigate, but especially for a young person. Because a patient essentially learns that they can't trust their own internal alarm system. Or, honestly, perhaps even more damagingly, they learn that the world simply doesn't care that the alarm is ringing in the first place.
Yeah, and this isn't some rare hypothetical mystery illness we're talking about. This is the daily lived reality for millions of adolescents who are suffering from endometriosis.
It's incredibly common, yet so misunderstood.
Right. And that profound disconnect between what a young patient is feeling and what the medical system actually sees, that is the focus of our deep dive today. We are pulling our insights from this highly comprehensive 2025 paper. It's titled Endometriosis During Adolescence, a narrative review.
It's a fantastic review, really thorough.
Yeah, the authors Caroline Ruth Mathias, George Condis, and Mercedes Espada Vaquero, they've pulled together the absolute latest research to understand how this condition uniquely affects teenagers. So our mission for you today is to explore why adolescent endometriosis is fundamentally different from the adult version of the disease.
Right, because it's not just the same thing happening in a younger body, it's biologically distinct.
Exactly. We're going to look at the stealthy biological mechanisms it uses to just hide from modern medicine. And then we're going to explore the cutting-edge science from like artificial intelligence to microRNA saliva tests that could finally end these agonizing diagnostic delays.
If we connect this to the bigger picture, the sheer scale of the problem is just difficult to overstate. Endometriosis affects roughly 10% of premenopausal women.
Wow, 10%. That's huge.
It is, but the critical data point in this research, the thing that really stands out, is that of those women, 70% report their symptoms actually started before the age of 20.
Ah, wow.
Yeah, and 40% say their symptoms began before age 15.
Wait, 40% before age 15. So this is fundamentally a disease that begins in youth.
Absolutely. It is an adolescent onset disease for a massive portion of the population.
Yet, despite the symptoms starting so early in a patient's life, the average delay from the onset of symptoms to an actual formal diagnosis is 8 years.
Yeah, 8 years of just unexplained agony.
And the research highlights a particularly cruel irony here, right? Like, if your symptoms begin during adolescence, that diagnostic delay can be up to 3 times longer than if they start in adulthood.
Which is just staggering when you think about it.
I mean, an 8-year delay is essentially someone's entire adolescence and young adulthood defined by unexplained chronic pain.
Right. It shapes their entire formative experience.
So, to understand why it takes nearly a decade to figure this out, we really need to look at what endometriosis actually does inside a teenager's body versus an adult's. Let's start with the symptoms. The brutal reality for these adolescents is severe period pain or dysmenorrhea.
Yes, and we need to be clear, we aren't talking about a bad cramp here.
Right. This is pain that entirely resists typical painkillers like NSAIDs or even standard contraceptive pills.
It completely bypasses those first-line defenses. The things that usually bring relief for normal menstrual discomfort, they don't touch this.
Wow. And it's not just during their period, right?
No, not at all. The clinical presentation often goes far beyond the menstrual cycle itself. These adolescents experience severe non-cyclical pelvic pain.
Meaning what exactly?
Meaning their pelvis hurts intensely even when they are nowhere near their period. It's just a constant chronic state. Furthermore, for nearly 70% of these young patients, the pain is accompanied by severe, debilitating nausea.
Okay, let's unpack this logically. Because if the pain is this severe, if a teenager is constantly nauseous, throwing up, missing school, and just completely unresponsive to pain medication, how on earth is the medical community missing this? Is the disease actively hiding from the tools we use to look for it?
Biologically speaking, the disease is absolutely hiding, and the mechanism behind its active camouflage is actually fascinating.
Really? How does it hide?
Well, in adults, when a surgeon looks inside the pelvis, endometriosis lesions are relatively easy to spot. They're often described as black, puckered, scarred, or fibrotic.
Okay, so they look damaged.
Exactly. They look like old, burned-out tissue because they are less metabolically active. They're essentially the visible blackened scars of a long-standing cellular battle.
So they leave this visible trail of destruction that a surgeon's camera can easily pick up.
Precisely. But when you look inside an adolescent pelvis, you rarely see those black, puckered scars. Adolescent endometriosis lesions are typically red or even completely clear.
Clear, like see-through.
Yes, practically invisible to the naked eye. And the crucial distinction here is that these clear or red lesions are highly biologically active.
So they're not just old scars, they're doing something.
Oh, they are very dizzy. They are heavily vascularized, meaning they are aggressively pulling in a rich new blood supply, and they are deeply entwined with the sensory nerve fibers in the pelvic region.
Oh, wow. So they're basically these microscopic, hyperactive little nerve hijackers. They're directly stimulating the sensory nerves.
Exactly. Because they're so biologically active and so intimately connected to the sensory nervous system, they cause excruciating pain. But because they lack that classic black fibrotic appearance, a surgeon could look right at a clear lesion during a standard evaluation and just see what looks like healthy, normal pink tissue.
That is wild. So the pain is at its absolute maximum, while the visual evidence of the disease is at its absolute minimum.
That's exactly it.
Well, it makes complete sense why these young patients are being told everything is fine. The doctors literally cannot see the source of the agony with the traditional methods they rely on.
Right, because they're looking for the adult version of the disease.
Because the disease is practically invisible in its early stages, and because it causes pain that mimics severe but, normal menstrual cramps, diagnosing it clearly requires a total paradigm shift in how we approach adolescent medicine.
It does. And that shift requires dismantling a massive wall of societal bias first.
Oh, the stigma. Yeah.
Yes. The stigma surrounding female pain is actually quantifiable in this research, and the numbers are stark. The source highlights that 63% of patients were explicitly told nothing was wrong by at least one physician during their search for a diagnosis.
63%. That's unacceptable.
It is. More than half felt they weren't taken seriously at all. We have a culture where adolescents are actively encouraged by their families, by their schools, and by society at large to just normalize their pelvic pain.
Right. If everyone around you insists that being a woman just hurts, you eventually stop looking for a medical explanation and just, I guess, accept the suffering.
Sadly, yes, that's what happens.
But the paper indicates we are starting to see a paradigm shift in how the medical community approaches the actual physical diagnosis, right? Like, historically, the gold standard for finding endometriosis was an invasive surgery called a laparoscopy.
Yes, physically going in with a camera to look around.
But now there's a strong push away from making invasive surgery the very first step, especially for young patients. The shift is moving toward advanced, non-invasive imaging.
Right, because the intention is to avoid putting a teenager under general anesthesia unless absolutely necessary. So the diagnostic pathway begins with imaging instead.
Okay, so the paper notes that transabdominal ultrasounds, the standard ultrasound where a technician just puts the gel in your stomach, those are usually recommended as the very first imaging step. I have to push back on the logic of this, though.
Oh, why is that?
Well, the paper also explicitly states that transabdominal ultrasounds are highly limited in actually finding these clear red endometriotic lesions. So if we know the ultrasound can't see the microscopic disease, aren't we just setting the patient up for another everything looks normal dismissal? Why even do the jelly on the belly ultrasound at all?
What's fascinating here is that the goal of the transabdominal ultrasound isn't necessarily to find the endometriosis. It functions as an exclusionary tool.
An exclusionary tool, so ruling things out.
Exactly. The medical team has to rule out major structural issues that could be causing the severe pain before they go hunting for microscopic lesions. Specifically, they're looking for Müllerian anomalies.
Okay, let's break that term down for the listener. Müllerian anomalies. We are talking about basic structural plumbing checks, essentially.
Precisely. Müllerian anomalies are structural birth defects, where the reproductive tract, so the uterus, the cervix, or the vagina, just didn't form quite right during fetal development.
Oh, I see.
So a transabdominal ultrasound is excellent at spotting if, for example, a patient have a blocked reproductive tract that is causing menstrual blood to back up and cause immense pain. You have to verify that the macroscopic anatomy is basically sound before you assume the problem is microscopic endometriosis.
Okay, that makes sense. But once you clear the easy structural suspects off the board, you still have a teenager in agonizing pain and you need higher resolution imaging. This
Wow.
is where the paper outlines a massive catch-22 for teenagers.
Yes, so limitations of the better imaging tools.
Right. The tools that are actually capable of seeing the subtle signs of endometriosis are transvaginal ultrasounds, transrectal ultrasounds, and MRIs.
And those modalities introduce significant physical and psychological barriers.
Right.
Transvaginal and transrectal ultrasounds are incredibly useful because they provide real-time dynamic imaging of the pelvic organs. The doctor can physically press with the ultrasound probe to see if the organs glide smoothly against one another or if they're stuck together by unseen clear adhesions.
Oh, like they're checking for mobility.
Yes, this is called the sliding sign. However, for an adolescent, especially one who is not sexually active, these invasive exams can be highly traumatizing. Many adolescents simply will not tolerate them, which is entirely understandable.
Of course it is. So if the dynamic ultrasound is off the table due to the physical and psychological barrier, the logical next step is the MRI. I mean, you just lie still inside a machine.
Well, MRIs are fantastic at identifying deep infiltrating lesions, especially in the deeper posterior compartments of the pelvis, because they allow doctors to review the pelvic anatomy in multiple high-definition planes.
But there's a catch.
A big one. MRIs come with their own set of profound limitations. They are expensive, they aren't always accessible in every medical facility, and they are famously claustrophobic.
Yeah, being in that tube is not fun.
Now imagine putting a highly anxious teenager who is already in severe pain inside a loud, confined tube for 45 minutes. It's a difficult proposition. Furthermore, an MRI is a static image. It completely lacks that real-time dynamic observation where a doctor can actually see if organs are physically tethered together.
So the diagnostic tools we currently have are either completely blind to the disease, psychologically traumatizing, or terrifyingly claustrophobic and static.
Pretty much, yeah.
It is a perfect storm designed to create an 8-year diagnostic delay. But because physical imaging is hitting this wall, the scientific community realized they had to stop looking inside the pelvis entirely. They needed a biological footprint.
Right. The research is pivoting rapidly away from spatial imaging and toward molecular biology.
And here's where it gets really interesting. The paper discusses a new approach called the endometriosis saliva test. I was initially skeptical of this. I mean, how a pelvic disease could be diagnosed by spitting in a tube, but the interim numbers they are reporting are difficult to ignore.
They're incredibly promising.
Instead of looking for physical lesions with a camera or magnets, scientists are analyzing microRNA signatures right in the patient's saliva.
Yeah. To understand why this works, we have to look at what microRNAs actually do. Think of microRNAs as the body's molecular managers. They help regulate how our genes are expressed.
Okay, molecular managers.
When a complex disease like endometriosis is growing aggressively in the pelvis, it doesn't just stay localized. It creates systemic inflammation and alters the body's overall molecular environment.
It affects the whole system.
Exactly. Those molecular managers shift their behavior in response to the disease, and those specific abnormal shifts circulate through the entire body, eventually showing up in bodily fluids like saliva.
Oh, that's brilliant. It's like a localized fire sending a very specific type of molecular smoke through the entire house.
That's a perfect analogy.
And the data the authors highlight shows an interim analysis with a 96.2% sensitivity and a 95.1% specificity. Let's translate that for the listener. It means the test is incredibly accurate at catching the disease when it is present and equally accurate at correctly ruling it out when the patient doesn't have it.
Exactly. It has the potential to bypass the trauma of invasive physical exams completely. It's non-invasive, it can be easily repeated to monitor the disease, and it is acceptable to a patient of literally any age.
Just spit in a tube.
Right. Though the authors do caution that the current high cost of this molecular technology acts as a significant barrier. It is not yet an accessible, cheap diagnostic tool.
Sure, but the proof of concept is there. And it's not just molecular biology stepping into the gap. Computer science is also playing a massive role. The paper highlights the integration of artificial intelligence in closing this diagnostic window, mentioning tools currently in development like Imagendo and Healthy AI.
AI is going to change the landscape here.
Yeah, the way this functions is almost like having a digital bloodhound. AI models are trained on millions of data points, allowing them to sniff out pixel density patterns in a standard ultrasound image, or even text patterns in a teenager's daily symptom diary that a human doctor might easily dismiss as just bad cramps.
And the supreme advantage of an AI diagnostic tool is that it does not carry the societal bias of a human practitioner.
That's a huge point.
It doesn't look at an exhausted teenager and consciously or subconsciously think she's just exaggerating her pain. It purely analyzes the pixel contrast of an image or the specific frequency of nausea reported in an app and flags the microscopic anomalies that correlate with the disease. It's a tool designed mathematically to find the invisible.
Okay, let's follow this logic through. Let's assume the technology delivers. A teenager finally gets that elusive diagnosis, whether it's through an AI flagging her symptom diary, a high-tech saliva test, or pushing through an MRI. We find the fire. My instinct says the treatment protocol is obvious. You send the patient to a surgeon, they cut out the active lesions, and the teenager goes back to living a normal life.
This raises an important question, though. That instinct makes sense, but it ignores the fundamental nature of how the human body processes chronic pain.
Wait, what do you mean?
Surgery alone is rarely a permanent solution, especially if there's been a long diagnostic delay due to a biological phenomenon called central sensitization.
Oh, central sensitization. If you're listening to this and you've ever dealt with chronic pain, or perhaps an old injury that still aches long after the tissue has healed, you might recognize this phenomenon. Your brain basically learns to expect the pain.
Exactly. That is neuroplasticity at work in a highly negative way. Remember that adolescent endometriosis lesions are heavily vascularized and deeply entangled with the sensory nerves.
Right, the nerve hijackers.
Yes. If those active, angry lesions are left undiagnosed and untreated for years, bombarding the nervous system with severe pain signals day after day, the adolescent's central nervous system physically rewires itself.
It rewires itself.
Yes, the spinal cord and the brain begin to amplify normal signals into pain signals. The arm system gets stuck in the on position.
Wow. The structural tragedy here is that once central sensitization sets in, even if a highly skilled surgeon goes into the pelvis and flawlessly excises every single microscopic endometriosis lesion, the severe pelvic pain might continue anyway. The brain has permanently memorized the pain, and it still feels the ghosts of those lesions.
Which perfectly illustrates why an 8-year diagnostic delay isn't just an inconvenience or an emotional burden. It is actively, structurally damaging to a developing teenager's nervous system.
So, if the goal is to stop this brain rewiring process before it becomes permanent, you have to shut down the source of the pain entirely to let the nervous system cool off. Are doctors essentially trying to put a teenager's reproductive system on pause?
That is exactly the medical strategy.
Yeah.
The management flowchart synthesized in the paper emphasizes a highly customized approach, but the primary mechanism of defense is hormonal suppression. You want to starve the endometriotic lesions of the estrogen fuel they need to grow, inflame, and bleed.
You're cutting off the supply lines.
Yes. First-line treatments are typically continuous oral contraceptives.
And the operative word there is continuous.
Absolutely. The goal is not to regulate the menstrual cycle. The goal is to suppress menstruation entirely. By stopping the hormonal cycling, the lesions are deprived of the chemical signals that tell them to become active.
But we established earlier that adolescent endometriosis is notoriously... Wait, so you can't just cut the lesions out and allow the teenager's body to resume its normal hormonal cycling?
No, absolutely not. Endometriosis has a remarkably high recurrence rate. If you excise the visible lesions but immediately allow the adolescent to resume normal estrogen production, the microscopic cells left behind will simply revascularize, and the excruciating pain is highly likely to return rapidly.
So the surgery is just a reset button, not a cure.
Right. You have to maintain that suppressed, paused state to allow the pelvic nerves to heal from the surgical trauma and to prevent the regrowth of those invisible, hyperactive red lesions. It is a profound tightrope walk for the medical team, balancing hormones, managing an incredibly aggressive disease, and trying to protect a developing nervous system from permanently memorizing pain.
This is just incredibly intense. We have mapped out an incredible journey today based on this narrative review. We started with the biological stealth of this disease in teenagers, those microscopic, highly active clear and red lesions that burn like fire by tangling with sensory nerves but effectively hide from the surgeon's camera.
Yeah. the active camouflage.
We unpacked the societal gaslighting that forces young women to endure an 8-year diagnostic delay because they are consistently told their agony is just a normal part of growing up. And we explored the necessary paradigm shifts, moving away from traumatic, static imaging and toward the digital bloodhounds of AI and the frontier of molecular diagnostics with the endometriosis saliva test.
Some really promising tech on the horizon.
Definitely. And finally, we tackled the high-stakes biological reality of central sensitization, where the brain rewires itself to expect pain, forcing doctors to rely on continuous hormonal suppression to starve the disease of estrogen. For you listening right now, even if this specific medical condition never touches your life, understanding the mechanics of this diagnostic delay is a masterclass in modern healthcare.
It really is.
It's a stark reminder of why we must continuously challenge the concept of normalized pain within the medical system. When a body is sounding an alarm, the solution is never to muffle the bell. The imperative is to find the fire.
That is the core takeaway. And it leaves us with a rather profound question to consider regarding the future of medical diagnostics. Think about the endometriosis saliva test.
Okay.
Imagine a day when that molecular test becomes cheap, universally accessible, and sits in every single primary care office. When we can finally hand a teenage patient a piece of paper that offers undeniable biological proof of her endometriosis. Will that physical proof finally force society to dismantle the deeply ingrained stigma that a young woman's pain is all in her head? Or will the medical system simply find new ways to dismiss the data?
That is a chilling thought, but an essential one to confront. A brilliant diagnostic test only matters if the person reading the results actually believes that the patient standing in front of them deserves to be healed. You have to trust your own internal alarm, but society must be willing to answer the call.